Hello and welcome to our SAGES Virtual 2020. This is my first Zoom lecture, and I'm so pleased that SAGES invited me to do this. And thank you to the committee chair for including me as one of the speakers in this discussion of not using mesh for hernia repair. So my topic is mesh choice. And what I mean by that is not which mesh to use, but rather how to discuss mesh choice with a patient, patient-specific and disease-specific choices, and I have absolutely nothing to disclose. What I'm going to do is I'm going to talk about patient factors. I'm going to talk about the preference for no mesh and how to get to the root of the reason the patient is requesting you not use a mesh. Then I'm going to present you the 2019 to 2020 data on mesh versus suture repair. I'm going to talk about the data on pregnancy and mesh repair. And then we're going to talk about disease factors, assessing recurrence risk based on size, location of the hernia, and that sort of thing. And then assessing morbidity and mortality risk for a specific patient. And finally, about using prophylactic mesh in patients. So when a patient doesn't want mesh, you have to get to the reason why. Maybe they heard it from someone, a friend or a relative had a bad experience with a mesh, or maybe they personally had a bad experience with a mesh in the past, and you're going to want to know about that. Maybe they got a letter from a lawyer saying, join our lawsuit against this mesh company because this mesh was bad. That can also be a reason. And sometimes just explaining to them the type of mesh you're using is one you've been using a long time or has never had a lawsuit. That sort of thing can help. They may have multiple allergies and be afraid there's something in the mesh that they might be allergic to, or they may have cultural issues. For example, a vegan might not want an animal-derived mesh, or porcine mesh may be difficult for some patients with certain religions to want. And then you want to talk about the patient, about the facts. So you want to give them the risk of recurrence and complications with and without a mesh, and show them what their risk and benefit is going to be if they choose not to have a mesh. You want to talk about the type of mesh you plan to use and your personal experience with it, if you have any, your personal data, or publish data on that particular mesh if you can look that up. And then finally, you want to, if it's a biologic, you want to discuss the source of the mesh, human, pig, cow, make sure that the patient is okay with that. So I'm going to discuss the data, the mesh versus suture repair in inguinal and femoral hernias first. And the best review of this is actually a Cochrane Library review, which came out in 2018. And this is mesh versus non-mesh for inguinal and femoral hernias. They looked at 24 randomized controlled trials. They found the recurrence rate favors mesh repair with a relative risk of 0.46. They also found, and this was moderate quality data, they also found that complications were divided. Mesh repair, you were less likely to see urinary retention with a relative risk of 0.3, and you were less likely to see neurovascular and visceral complications, the relative risk of 0.6. And that was moderate and high quality data. With suture repair, we saw less seroma formation with a relative risk of 1.6 for favoring, obviously, no mesh, and less wound swelling, which also favored no mesh with a relative risk of 4.46 with mesh. So there was low quality data for surgical site infection, which seemed to favor suture repair, and for hematomas, which seemed to favor mesh repair. So in any case, the one thing for sure is that the relative risk of recurrence is about 0.46. And this is the forest plot showing that. If you look at the data for mesh versus suture repair in a strangulated inguinal hernia, there was a meta-analysis that looked at 2 randomized controlled trials, 3 prospective and 4 retrospective trials on strangulated inguinal hernias in mesh, published by Hassan in 2014. This one showed low recurrence of in the mesh group with a risk of 0.2. And it also showed a trend towards lower infection rates in the mesh group with an infection rate of 0.46, but this was not statistically significant. The forest plot of mesh repair again shows recurrence rate favored Liechtenstein over the non-mesh repair. If you look at biologic versus synthetic mesh for inguinal hernias, there was a systematic review of this with a meta-analysis of 5 randomized controlled trials looking at 382 patients. 179 received biologic and 203 received a synthetic mesh. This was done in 2015 by Fang et al. And there was no difference in hematoma, groin pain, or recurrence rate. Seromas were more common with biologic mesh repair, and biologic mesh repair took significantly longer. If you look at heavyweight versus lightweight mesh in laparoscopic and endoscopic repairs of inguinal hernia, so this is just looking at laparoscopic and robotic treatment of inguinal hernias, there was a meta-analysis of 12 randomized controlled trials with 2,909 patients. This is one of the better studies that I looked at. The follow-up was 3 to 60 months, and this was published by Backer in the Annals of Surgery in 2020. It showed that lightweight mesh had a higher recurrence rate, the relative risk of 2.2. It also showed that non-fixated lightweight mesh used in direct hernias had a significantly higher recurrence with a relative risk of 7.27. So there was no difference in pain, severe pain, or foreign body sensation using a heavyweight mesh. So this basically showed that in larger direct inguinal hernias, it may make more sense if you're fixing them with a laparoscope to use a heavyweight mesh over a lightweight mesh. So what about umbilical hernias? Mesh versus suture repair. There were several systematic reviews and meta-analyses that came out in the last year. The first one looked at 6 randomized controlled trials and 8 observational studies of mesh versus suture repair published by Madsen in 2020. This one showed recurrence was lower in the mesh repairs, the relative risk of 0.48. Seroma was higher in the mesh repairs with a relative risk of 2.37, and hematoma, surgical site infection, and chronic pain rates were not statistically different. Another review and meta-analysis published looking at, again, 6 randomized controlled trials, 742 patients, published by Aolfi in 2020 in hernia, showed that mesh repair leads to lower recurrence rate with a relative risk of 0.27. And this was a very significant p-value. Finally, it showed that hematoma, surgical site infection, and seroma rates were not statistically different. Another meta-analysis, including 4 randomized controlled trials of open mesh repair versus suture repair, evaluated 620 records published in 2019. This was Shritha et al., and it showed the recurrence rate was lower in mesh repair with a relative risk of 0.22. Hematoma, surgical site infection, and seroma rates were not statistically different. Guidelines for umbilical and epigastric hernia repair came out with European and American societies publishing recommendations in the British Journal of Surgery in 2020. They recommended the use of mesh for repairs of greater than 1 centimeter hernias with strong evidence. They advised smoking cessation for 4 to 6 weeks and a BMI less than 35, but there was weak evidence for this. They recommend the use of preperitoneal flat mesh overlapping 3 centimeters for defects 1 to 4 centimeters in size. And there was again weak evidence to this, and this was including primary closure of the defect. Laparoscopic or robotic repairs were suggested for any umbilical hernias greater than 4 centimeters with defect closure when possible, and a 5 centimeter overlap. Again, weak evidence. There was strong recommendation to consider laparoscopic and endoscopic or robotic repairs in patients at increased risk for wound complications. And so some of these had good evidence. Most of them were based on expert opinion. This is the algorithm for repair of an umbilical and epigastric hernias put out by the same guidelines. And I'm not going to go through these in detail, but I put it in the slide deck so that you can go back and refer to it or look for it when you want to. Finally, mesh versus suture repair in ventral and incisional hernias. We see a systematic review of 10 randomized controlled trials with 1,215 patients, moderate risk of bias by Mathis, published in 2016. This showed the recurrence with mesh repair at a relative risk of 0.36. Other complications were not different from suture repair versus mesh repair. Long-term patient-reported outcomes in ventral hernia repair. There was a systematic review of 24 studies published by Sando and Hernia of 2020. There was no improvement in patient reported outcomes in small and medium umbilical and incisional hernia repairs. However, there was relevant improvement in post-op pain, physical impairment, and social involvement seen in large-sized incisional hernias. Stoma-related complications also improved in patients with medium-sized peristomal hernias, indicating that even patient-reported outcomes indicate that we should be fixing the larger peristomal, medium-sized peristomal, as well as larger incisional hernias. Synthetic mesh versus all other repairs in contaminated ventral hernias. So it was an interesting study, a large retrospective review of database containing 541 patients, published by Warren in the Journal of the American College of Surgeons in 2020. I thought this was worth mentioning. They took 245 clean contaminated, 214 contaminated, and 18 dirty cases. They looked at 402 synthetic mesh placements, 46 suture repairs, 38 biologics, and 55 absorbable meshes. And what they found is that recurrence was lower in the synthetic mesh repair, as you would expect, but also the risk of surgical site infection, mesh removal, was equivalent across all repair strategies. So it looks like there is no reason to use a biologic or a suture repair or absorbable. Now, this is a retrospective study, so take this with a grain of salt. It may be that in certain situations, you still will want to use a biologic mesh. However, this is reassuring that even in clean, contaminated, and contaminated wounds, a synthetic mesh can be safely placed and will significantly decrease the risk of recurrence. So mesh versus suture repair prior to pregnancy. There's a propensity score match study of the Danish ventral hernia database that looked at 632 women from 2007 to 2014. This was published in 2019 by OMA. They were sent a questionnaire and the response rate was almost 70%. So 441 patients were evaluated. The 8-year recurrence rate was 24.8% in all comers. And this decreased risk of recurrence with mesh was a relative risk of 0.44, whereas there's increased risk of chronic pain with mesh at 5.7. So this shows mesh repair versus suture repair recurrence rate at 7 years, and this shows mesh and suture repair in patients who did not become pregnant. So if the patient is planning to become pregnant, they are going to have a higher risk of recurrence, but they also have a higher risk of chronic pain. So it's something to consider and discuss with your patient. So summary, what do you tell your patient? Open is a 50% reduction in risk of mesh repair than tissue repair, and biologics have a higher seroma rate. Laparoscopic, heavyweight mesh with fixation has half the recurrence rate of lightweight mesh. Umbilical hernias greater than 1 centimeter, mesh cuts the risk of recurrence by 60 to 80% compared to primary repair. There may be small increase in risk of seroma formation in some studies with a mesh repair. Ventral hernias, synthetic mesh provides a 60% decrease in recurrence rate without significant difference in complications. In women who are planning to get pregnant, mesh will increase the risk of pain in the abdomen, but significantly decrease the risk of recurrence. So what about disease factors? You want to discuss with patients the risk of recurrence based on things that are changeable that you might be able to help them improve. So disease-related risk factors in inguinal hernias, there was a meta-analysis, a total of 376,000 patients published in 2014 which showed increased risk of recurrence for female sex, BMI greater than 30, direct inguinal hernias, recurrent hernias, and smoking, with no increased risk with age or family history. So if you have a female patient with a higher BMI and a direct inguinal hernia or a recurrent direct inguinal hernia who's smoking, they have all the risk factors. And there's even more reason that you would need to use a mesh in that particular patient. NISQIC risk of repeat ventral hernia repair looked at 3,730 cases reviewed with 247 re-repairs. This was published in 2015 by Stay. And they saw an increased risk of reoperation was more likely with smoking, high BMI, history of surgical site infection or open wound at the original repair. Predictors of wound infection in ventral hernia repair, another study, a veteran study looking at 1,500 veterans, published by Finnan in the American Journal of Surgery in 2005, showed increased risk of infection was based on steroid use, smoking, prolonged operative time, and absorbable mesh use. So I know you all know this, but I'm just giving you the data behind this. You all learned this in residency. I want you to have data to present to your patients so that you can encourage them to use a mesh, to consent to a mesh if you think one is appropriate. When you assess morbidity and mortality, there's actually a new study out in hernia in 2020. A NISQIP study looked at 9,931 patients. Again, this is a database study, but they looked at the frailty index predictive outcomes. And what they found is the risk of complications were higher with the following factors: dependency, diabetes, COPD, CHF, hypertension, peripheral vascular disease, smoking, age greater than 60, wound contamination, and incarcerated hernias. So again, presenting the risk of complications is important. They did find that there was no risk associated with history of stroke, MI, recurrent hernia, or prosthetic mesh. So the wound infection risk was not changed by, the morbidity and mortality was not changed by having a recurrent hernia or using a prosthetic mesh. And presenting these factors to your patients may allow them to understand the benefits of using a mesh. So when do we use prophylactic mesh? Another issue that comes up often. Long et al. Published a report of colorectal operations in 935 patients with midline or ileostomy closures, and 23.6% underwent prophylactic mesh placement. In this review, published in 2020, they found that seromas and chronic pain were slightly higher in the mesh group, while wound infections were no different. And the hernia recurrence was significantly higher in the non-mesh group, 13% versus 1.3%. So significantly different risk of a hernia if you use a mesh, with a slight increase in chronic pain and in wound infections. Prophylactic mesh at the stoma site closure, in a systematic review and meta-analysis of 6 comparative studies, 1,683 patients underwent stoma closure, with 669 using mesh and 114 without prophylactic mesh. And half of these about were polypropylene, the other half used biologic. And this was published in 2020 again, and it showed a significant decrease in incisional hernia with mesh with a risk of 0.22. It also showed a significant increase in OR time with mesh of about 47 minutes. And there was no difference in surgical site infection, bowel obstruction, seroma, leak rates, hematoma, or length of stay. So it showed that you can use either biologic or non-biologic meshes. It will take a little bit longer in the operating room, but it will significantly decrease the risk of incisional hernia. In a randomized controlled trial, ROCSS, that was across 3 European countries, looked at 790 patients that were assigned to a standard stoma site closure versus a porcine biologic mesh placement in the intraperitoneal position with 3 centimeters of fascial overlap. They found a significant decrease in clinical hernia occurrence at 2 years, the relative risk of 0.62 when they used the biologic mesh, no difference in symptomatic hernia, wound infection, or seroma formation. Finally, prophylactic mesh in the setting of abdominal aortic aneurysm repair. A systematic review and meta-analysis found 15 studies looking at closure of the open abdominal aortic aneurysm repairs with 3,399 patients. And this one was published in 2020 again. And they found that the 4-to-1 suture to wound length ratio has a lower hernia recurrence with a relative risk of 0.42, and that prophylactic mesh significantly reduced the risk of incisional hernia with a relative risk of 0.24. So prophylactic mesh in this situation may also be beneficial. Thank you for attending, and come visit California once you are able to travel again. You might be able to see one of our big trees.